and welcome to After the Chaos. So, we're going to talk about our conversation with Mindy the other day. Um, I have so many thoughts around, we always have so many thoughts around technology implementation and how it should be done and what we're doing. But the point that stood out to me the most was that, the implementation of the EHR was just replacing the pen with the keyboard. And can we just expand on that a little bit? Because that is not my understanding of technology and implementation. It is not just, hey, this is what we do. Oh, here's now a technology version of that. Like, oh, now here's an automated version of that. It is actually an entire redesign of the way that we work, the way we interact with each other, the way that we interact with the technology. I think that's where the EHRs and why we're kind of like stuck in this loop right now is because the point of it was not well understood.
Yeah, I think you're right. I think meaningful use, she kind of hit on early as a topic. And I think looking back, anybody who studies meaningful use now is like, it was basically unmeaningful use. I think her quote was pretty cute, pretty funny. Like I wrote it down. It was like, we didn't modernize healthcare with EHRs. We traded a pen for a keyboard. And in fact, that keyboard takes more time than the pen ever took, which is even more painful. I think when I think about the EHR now, there's two things that let's talk about what the EHR does well. Billing. It was created to bill people, bill things, and it's like a repository of data. I think what it does terribly is it does not connect the care team. It does not orchestrate care. It does not increase quality of care. It does not help like the result over here get to the right person on the care team over here. In fact, it creates all of these like tranches and layers and like segmentation. The other thing we see is like, in basket 77 to 100 messages a day, I think is the latest research into a doctor's inbox and or in basket. And you think about that and you're like, okay, so they're seeing patients for 8 hours a day, right? To keep
Hmm.
their productivity up. And then they have 77 to 100 emails to go through. Like that's essentially what it is. Half of that is really important stuff. Some of it's not. But it's like that's a real break point that EHRs are not really helping with. I think there's a ton of tech that's been stacked on top of the in basket, right? That's been helping figure out prioritization of that. But the other thing is my chart. My chart I was looking up because somebody was like, "Oh, let's just integrate with our my chart." And I was like, "Great. What are your success rates with your my chart? Like what are your patient engagement rates?" And they were like, "Oh, they're pretty good." And I was like, "Okay, great. What's pretty good?" And they were like, "About 50%." And I'm like,
Hmm.
"So it's a 50-50 shot that your patient got the message and that is successful." And they were like, "Yeah, a lot of people are like at 35%." And I'm like, "Oh, got it." So I'm like, how is this our reality that like we spent when you talk to health systems, it's their biggest bill that they spent money on in the last decade was their EHR. And yet the EHR is taking us further and further away from solving the problem.
Well, I think in theory, like you said, it's about information organization and getting it in the right spot to the right people. I think in theory, that's what it's supposed to do. But it doesn't ever translate to that because we're not redesigning workflows. Like we were saying, we're not enhancing the workflow with the technology. We're not like melding like hand in hand the workflow and the technology to support it. We're having solutions in search of a problem or problems that are not well understood and then designing solutions to meet half the problem, but not the other half. And so when you're a clinician trying to interact with a system that was half designed, it feels like it shouldn't have been designed at all. It feels like you said, more harm than good. And the expectation of what it should do actually, I think, is causing a ton of injury for people who are interacting with it because you expect something that's so different. I expect to be able to get that information out. I expect that to go to the provider and that provider to be able to respond back to me. In theory, that's how it could work, but it just doesn't for so many reasons. I think that clinicians being part of the design. I know we're talking about nurses, but this could be technologists, this could be physicians, in figuring out a way that is meaningful, purposeful, useful to have them interact with not just ideation of like what problems are we trying to solve and how can technology do this, but then through the redesign. Okay, because the technology, when you put it in place, I have to now change the way that I work to do the work well, and we have to work together so the tech can actually support us and we can actually use it. And then the continuous improvement of that, those are only the frontline staff can do that work. And so how do we alleviate their time to do that? How do we provide them with the support to have that skill set to interact with it? And how do we have that flexibility in our technology to where we can continue to co-design a future that is actually meaningful?
Yeah, I took away kind of some of the similar thoughts there. Like, and in these 30-minute segments, we can't get to everything. So Mindy was absolutely right in, I think she said, like, if nurses aren't involved in something that's a workflow or a technology that's going to involve them from ideation, the technology will fail, like full stop. Like, yeah, agreed. The other thing she said is like involve them and like not just one of them, but like involve a room of them. But like I think the question layers, like if we were doing a second session and we were kind of going on with like Q&A, it would be like, okay, great. How do we design that? Because nurses are nurses and clinicians. And like you said, it could be anybody on the care teams that this is impacting. Like they're very busy too. And so from my technology side of my brain, I'm like, great. I'm going to go out there and I'm going to ask them what all of their problems are. Right. And then I'm going to take that and I'm going to take it back with my tech team and I'm going to be like, these are all the problems. How would you solve it? And then I'm going to come up with a framework of just like a demo, not connected to anything. We're not in building mode yet, but we're like, we've got a demo. And then we go back to that room. And with the very little time that we have with them, we say, watch this demo. You guys described these problems. Are we headed in the right direction here? Will this solve your challenges? Will this solve your problems? And then let them react, let them iterate it because they'll have a lot of, I mean, nurses are little mini engineers. We know this.
Yeah.
They'll have so much feedback and be like, well, not this, but this, and yes to this. And oh my gosh, I love that. And then take that again, take it back again, iterate it again. You're still in demo mode. You're not building. Then come back with your second, one more iteration. These could be 30-minute cycles that you have with them to just like really use their time well. This doesn't have to be hours and hours and hours. This doesn't have to be death by committee. This doesn't have to be analysis paralysis. But I feel like that's what it turns into a lot of times in the hospital.
Yes.
If somebody's like, well, we need feedback. And it's like, well, we're going to schedule 6 sessions over the next 3 months. And then we're going to sit down for 2-hour chunks of time. And it's like, oh my gosh, like think like a startup here for a second. Like we can literally build, like Claude could build this in 6 weeks. Like, so yeah, that's kind of where my head went as she was talking is like, all right, all good points. Involve the nurse, involve the clinician, let them be from ideation onward, but like be in good usage of their time, come to them with the product and let them react, come to them with the demo, let them react, and then go to build phase. Was kind of what I was thinking.
Yeah, but can we just say how important it is because you are a nurse. Like you understand when they're like, I have a problem with this. You're like, oh yeah, I lived that. I
Yeah.
know what you mean. I know what you mean here. And they may be saying something that is very like personal, and you can translate that into that's workflow, that's information, because of your clinical understanding. And can we just talk really quickly about how many technology vendors have not one clinical person on their team, not one nurse, not one doctor, not one technologist, not one house cleaner who worked in the hospital, and how that makes it almost impossible for them to do this iteration to meet them where they're at because your clinical knowledge actually helps like translate that clinical technology barrier that we so often have with these teams. But that's a huge red flag to me. If anytime I see a technology team that has not one clinical person on it, I'm like, okay, this is going to be a lot of work to get this to actually be useful in the bedside.
And you see it all the time now. I think it's because, well, a couple things. You're right. I'm the minority in every room that I'm in that I have a clinical background, can understand the workflows, can speak the language, and can actually be in the tech. Like that is a unique quality. I think it's so interesting though, because we've been successful, I have a lot of health tech CEOs that are either just starting on their journey or they're like a year into their journey and they're like, talk to me about how you drove this type of success. Like, come look at my products, like come help me with messaging, things like that. And of course I spend the time and I do it. And you're right. What I notice right off the bat is they'll go into this great tech demo, right? Real deep on the tech. And they really will never even go into what problem that they're solving. I'm like, let's like go back a click. Like, what problem are you solving for this clinician? Like, wh- you started immediately with what the tech can do and what feature and functionality and what your model can do and like what latency you have and all of these like things in the background, but like none of that matters in the like it doesn't matter that you built a really cool thing if it doesn't
Mhm.
solve a really big problem. I think one of the things that we said in the what was it? Something in the hold on, I'm looking back at my notes. If your solution ends up in a drawer, then you didn't solve the problem. I mean, I love that, and it's the truth. People are like, "I built this super cool tech, and I don't know why it's not being successful out there." And it's like, well, because you really didn't focus on the problem. So,
That's also a part of tech development that, when you get caught up in the features and like, what's the cool new thing? You forget number one, those are solutions in search of problems, not problems in search of solutions. And the tech has to be designed to validate that it actually solved the problem that it intended to solve. And so when we look at like data and analytics around like embedded in the technology or that's part of their features, it should be this is what we set out to do. This is how you'll know that that happened. It should be a direct one to one. The outcome data in the tech should be that this is we solved the problem that we set out to solve. And there are so many times where that is either non-existent, it's not clear, it's not framed correctly and so it doesn't, or they didn't know what problem they were trying to solve in the beginning and so none of that aligns. So I think when we're helping healthcare organizations and our frontline staff and our clinicians engage with technology and make selections, these are really critical things that you should be looking for. Number one, do they have clinical staff on their team? Number two, can they clearly articulate the problem that they're trying to solve? Number three, can they clearly measure it? And then number four, does it have the functionality that matches your workflow and supports your workflow and makes your workflow better, not just different? Like,
yeah. So,
oh, so
uh,
much I could say here.
oh, I know. I so much. Well, I know we need to wrap up, but I think the last thing that like I'll close with is when we asked Mindy, great, how do we not repeat the mistakes of the past? And she was basically like, early electronic health record implementations fell short by simply digitalizing the existing workflow. Exactly what you just said. It just took like a
Mm,
broken workflow and just digitalized it. It didn't like redesign it. It didn't rethink it. It didn't like change anything. It was like, oh, you're doing this on paper. We're just going to digitalize it. And so we have a real opportunity here to number one, not repeat the mistakes of the past and do this all over again with AI, but to think in redesign mode. Like even with my executive team, I just had an executive retreat and I called it unbound. I'm like, don't think in a box. Don't think in this is how it's always been done. Don't think in like this is how we need to do things. And I think a little bit healthcare needs to do that to break apart some of these things that are not working. I think we can all say that healthcare today and workflows today in hospitals are not working with the administrative burnout and the burnout on nurses and the burnout on physicians. And when you literally look at those surveys, a lot of them have to do with the EHR and documentation and administrative burden and like doing stuff that they shouldn't be doing as clinicians. And so I think we have a real opportunity to not make mistakes of the past, but to use AI as a redesign moment and really rethink some of these things that we're doing. Will it be allowed? Who knows?
I know healthcare likes to be what it is. It's designed exactly. The results that we get is how it's designed. Um, but I think there are people out there. I see them pop up every once in a while. And you know what is the most refreshing part is those who are committed to hope, those who are committed to creativity and curiosity. And like you said, getting out of the mindset of how we've done things in the past is how we need to do them in the future. And I think that is why some of these conversations are so important, and why looking at other industries and our own work, our own like personal worlds are so important to healthcare, because there are so many great ideas that are coming up in just our personal worlds that we can then take and translate and apply to healthcare if people are willing to go.
I
It's
agree.
going to be good.
Good to see you, girl.
You too. Right.
Thank you guys.
Talk soon. Bye.